Coming now to presenting the 5 R's, the 5 rules in the visual field interpretation. And I would like to thank the popular lecture on this topic, the Forge lecture focusing ophthalmology and reframing glaucoma evaluation, which has been done and sponsored by Allergan in 2013. So starting with these 5 rules, 5 R's, the first R is the right test, then reliability, then the review of probability plots, then the RNF layer patterns of loss, and then reaffirming the diagnosis. And we'll explain each rule in details in the following slides. First rule, be sure that the right test was used. So the right test, we should come across all these points. Check the strategy, check the stimulus size, the field size, the eye, the aid by confirming the date of birth, the pupil size, and the refractive error. We'll see here the OD, which means the right eye. We'll see here the stimulus size, so it's 3 and wide, background 31.5 apostille, the strategy theta fast, pupil diameter here it's missing, should be mentioned. It should be more than 3 millimeter, and visual acuity also should be mentioned. And here the refractive error +2, and here is the date of the test, the time of the test, and the age of the patient. All these should be confirmed before starting reading the visual field printout. Okay, so we'll confirm the right strategy by confirming the theta standard. As we say, theta fast, it's not recommended for patients with glaucoma because it can underestimate the scotomas. So ideally it should be theta standard, the Swedish interactive threshold algorithm. Here you will find the strategy theta standard. Then you will check the right test stimulus size was used, and we said that the Humphrey visual field analyzer used the Goldman size 3 as a standard. Sometimes you can use the size 5 as we said for advanced visual field loss or decreased visual acuity. This is the 5Y stimulus in these cases in the advanced glaucoma. Then you should check that the right field size, as we said, the 24-2 is the standard size, central 24-2 threshold test. However, 10-2, it's very important in advanced glaucoma to check the progression, and it's very important for visual field loss within the central 10 degree of fixation. As we said, like early glaucoma or glaucoma suspect, 10% of them will be having defects and on 10-2 test strategy. Then you will check that the right age, the date of birth of patient has been reported. Why this is important? Because there is correction to the normative database. There's a Goldman table that adapted from the Humphrey field analysis instruction booklet. Depending on the age, they will correct for the refractive error. For example, if the patient is between 45-49 years, they will add +2 diopter sphere, and that's why they correct normative database. So very important, please check the age, check the date of birth for the patient, and also you will check the refractive error. You will see the refractive error, for example, for this patient having -1.25 diopter sphere, and also the correct pupil size more than 3 millimeters, because small pupils, meiose pupils, or people taking pilocarpine drops or any miotics agent will have small pupils, so they can block the peripheral stimulus, sometimes causing false peripheral decreased retinal sensitivity and therefore false peripheral field effects. So it's very important to check the correct pupil size. Here it's mentioned 3 millimeters. The second rule, Coming to the second rule, we should check the reliability of the field. Is this printout reliable or no? By main three indices. These indices are the false positives and false negatives and the fixation losses. I will explain these three in details in the following slides, and you will see them in the printout in the up left side corner. Here you will see the details related to the brightness, and here you will see the data related to the reliability indices. The first indices is the false positive rate, which is very important indices to check that this visual field printout reliable. And it's the percentage of the time that patient responded in the absence of stimulus. And the ideal rate should be less than 10%. If you see false positive rate more than 33%, this is unreliable test, and you should be cautious when you see that the false positive rate more than 25%. Why? Because elevated false positives can artifactually improve the appearance of the field, and there's some patients, they just keep clicking, they calling them trigger happy because they keep responding in the absence of any stimulus. So this is very important. Reliability in this is you should always check it before reading the printout, and here you see false positive errors 2%. Ideal should be less than 10%. Coming to the second one, which is the false negative rate, the second reliability indices, which is the percentage of time that patient failed to respond to a stimulus that should have been seen based on past responses. So it's the false negative, basically, is a negative response with brighter than the threshold stimulus in previous tested points. So the patient will see a point, then the testing machine will show at the same location higher threshold stimulus. The patient should see it. However, the patient will not click, will not respond. And these seen especially in patients falling asleep, can reflect fatigue. And if you see it more than 33%, it's unreliable, and you should use it with caution in more than 25% false negative rate. However, some testing algorithms have no longer using the false negative rate index. Why? Because in advanced visual field damage, when you have visual field damage, the false negative rate will be higher. Will be high because of the variability in receiving the stimulus in these advanced visual field damage location. So they say that false negative rate sometimes can be not related to fatigue or falling asleep, but related to advanced visual field damage. So some tests, some doctors, they don't depend on it fully, but they depend mainly on the false positive index and the fixation loss that we'll discuss in the following slide. Coming to the fixation losses reliability index, this is the percentage of the times that the patient responded to a stimulus that presented at the plotted blind spot. And this is, we call it Hale-Karakow method, where they present a point to the blind spot, okay, and the patient will respond. So there is no way how he respond to a stimulus presented at the blind spot. However, so consider as fixation loss. However, it has main drawback. We'll talk about it in the following slide. So fixation losses usually increase if the patient doesn't maintain fixation, keep moving his eye, the patient head moves, or the blind spot was incorrectly located at the beginning of the test. And this is the main drawback of the Hale-Karakow method, where they present a stimulus to the plotted blind spot. Because if you locate the blind spot incorrectly in the beginning of the test, this fixation loss measurements will be unreliable. And you should use with caution when you see the rate more than 20% fixation loss, and if you see that the fixation loss rate more than 33%, this is unreliable test. Okay, and here you see the fixation losses is 4 out of 15. So as we said, the original method was Hale-Krakow method, where they present stimulus at the plotted blind spot mapped in the beginning of the test. However, the main drawback that if you incorrectly locate the blind spot at the beginning of the test, this will increase the fixation losses falsely, and it will appear that the test is unreliable. So what Humphrey Visual Field did, they use what we call it gaze tracker, where they use infrared light in order to check the gaze stability throughout the test. And you will see at the bottom of the printout gaze stability line, you will see it like a line like that. Here in these points, it means that the gaze was stable. However, when you see it up, it means that the eye moved. So upstrokes means that there was increased eye movement, and if you see downstrokes, it means that there was lid movement. So this new technique by Humphrey Visual Field Analyzer is much better than the original method, Hale-Krakow method, which depends on the blind spot. However, the gaze tracker depends on infrared light that follow and control the gaze throughout all the test. We have other indices, just other clues that this test is not reliable, is unreliable. But these points are just clues that help you to understand the full printout. So, short-term fluctuation. Short-term fluctuation means that they retest 10 pre-selected points and then they calculate the difference between the original test and the retest threshold. So first they will select 10 points that the patient answered to them. Then they will retest these 10 pre-selected points, and then they will calculate the difference between the original test and the retest threshold. And if they see that the difference more than 4 decibel, so this means that the short-term fluctuation increase. And this measures the consistency and indicator of reliability. And also can be one of the early signs of glaucoma. Sometimes the patients see it and sometimes doesn't see it. So as we said, this short-term fluctuation, one of the indicator of consistency and reliability. If it's increased, there is suspicious. However, the CETA algorithm doesn't calculate the short-term fluctuation. Okay, we have what we call corrected pattern standard deviation to the short-term fluctuation, and this corrected pattern standard deviation, we'll talk about the pattern standard deviation the following slide. The pattern standard deviation will be corrected to the short-term fluctuation, and it measures the localized variability, the localized irregularity. So if you see a high corrected pattern standard deviation, it means high localized irregularity and highly suspicious for glaucomatous damage. And in Octopus, not in Humphrey Visual Field, care always must be taken when you see the reliability factor value is more than 10%, which is mainly depending on this short-term fluctuation during the test. So it's like intra-test variability. Not only that, we have another others reliability indices. The reliability is low when there is more than 550 stimulus are projected, or when the test takes more than 18 minutes. Usually, to determine the threshold for one test location, 5 stimulus are needed. In patients with field defects, more stimulus is needed. So if you see that the stimulus more than 550 are projected, or the test takes more than 18 minutes, it means that the reliability of the test is low. Always we have very popular field effect on the grayscale map in the visual field printout representing reliability index, the cloverleaf pattern. If you see this cloverleaf pattern, it means that the patient becoming fatigable inattentiveness with time, and I will talk about it just in the following slide. And also, if you see increased eye upstrokes or lid downstrokes movement on eye tracker line or the gaze tracker line, it means that there is some unreliability because of the fixation. So this is the unreliable field because of the cloverleaf appearance, which means that the patient becoming fatigable, becoming inattentive, becoming doesn't concentrate, losing concentration. So they will test in the beginning of the test very well. However, when they coming with time, they will lose concentration, lose energy and motivation to respond well. So this appearance of the field like cloverleaf, it will show. So the four primary points around the fixation are checked and confirmed. If you see, then here you will see this is all field losses. This cloverleaf patterns means that the field is unreliable. So rule number 3, review the probability plots. Coming now to the global indices, the most important one, and we'll talk about the most two important global indices. The first one is the mean deviation, the MD, which is from the just the name you understand that it's talking about the mean, average, and deviation. So it's the average loss of the entire field in decibels, or in other ways, the depression, the loss from compared to the age normal halo vision. As we said previously, the halo vision is like conceptual model to understand the visual field, normal and abnormal perimetry, representing the hill. This the maximum point of the hill is the fovea where there is the maximal visual threshold sensitivity, and when you go to the periphery there is reduction in this retinal sensitivity to the threshold, to visual threshold. And if you see in a glaucoma patient, they will start losing in periphery. However, in patient, for example, with optic neuritis, will start loss of the central hill of the vision. So, if you see this average loss of the entire field decibels compared to the age normal corrected data, give you the mean deviation. And for example, if you have a patient with minus 4 decibel, it means that it has on average 4 decibel loss less than the normal age adjusted population. It means that he has 4 decibels depression at all points in the field, or depression of 8 decibels over half of the field. Both of them would give MD or mean deviation of 4 decibels. The most important point, this one, the more negative MD, the more worse field. So if you see here minus 10, it's not like minus 1 decibel. And this probability, the p-value is the probability is given for that MD would occur in normal individuals. So this MD, for example, can happen in less than 5% of normal individuals. And if you see it 1%, it means that this MD mean deviation can happen in less than 1% of normal population. So 99% of this MD having abnormal result. You understand what is the meaning of p-value? It's like p-value in research. Coming now to the second most important global index, which is the pattern standard deviation, which is a measurement of focal visual loss. So it's a measurement not of global, of focal field loss, which means that it's the standard deviation of each point from the age corrected normal. And it measures the variability or local irregularities of the field. The more positive, the more bad. Not like the MD, the more negative, the more bad. Here, the more positive, higher pattern standard deviation means higher variability, higher irregularity in the field, which means there is localized field damage. And in the ocular hypertension treatment study, the PSD, the pattern standard deviation, identified as one of the out of 5 important contributors to the risk of developing glaucoma. However, this pattern standard deviation in normal patients or severely affected visual field, they will have low pattern standard deviation, because in advanced glaucoma, as we say that this PSD, the pattern standard deviation, can decrease because the damage is no longer focal. It will be all the field reduction. There is like a generalized reduction in the visual field, like tunnel vision. So because there is no localized irregularities because of the advanced loss, the pattern standard deviation will be low. However, in general, the higher pattern standard deviations means the greater localized field damage. As we said, coming to the numeric results and grayscales, these are the numeric results and corresponding with a map, grayscale map. We have a threshold sensitivity map. This threshold sensitivity map, it has numerical threshold sensitivity of each location by decibels. And this one, the map you should depend on. And this corresponding grayscale map should be used for education for patients. And the higher the threshold value, or the brighter the grayscale, means the higher sensitivity. So if you see blackish, the grayscale means that the patient has low sensitivity. Okay, the higher the threshold value, it means the brighter the grayscale and the higher sensitivity. These probability plots divide into the total deviation and into the pattern deviation. And we say that you should depend on the numeric plot, not on the grayscale. Grayscale should only be used for patient education. So these are the total deviation and the pattern deviation. And the total deviation, like representing like the mean deviation, the MD point. The threshold at each point corresponding to the age-matched data, and the pattern deviation representing the localized irregularities like the PSD, the pattern standard deviation. So here the total deviation probability map or numerical probability map, and here is the pattern deviation probability map, and you will see along with the grayscale map and the bottom of the printout. Sometimes the grayscale and probability plots may not agree. That's why I told you should depend on the numerical probability plot, because this is the more accurate than the grayscale map. So this grayscale map, it can give you impression that this field is normal. However, when you see to the numerical probability plot, you will discover that this patient has a scotomas and field effect, and it's abnormal field, comparing to just looking to the grayscale map. So please look at the numerical probability plot. These total and pattern deviation are one of the most useful aspects of the automated perimetry. We said that they compare the field data of the patient response to the normative age-matched database. They examine the difference points. You should examine the difference points. Not only that, the number of contagious difference points, the location of these difference points, and the severity of these difference points. So always, please, these 3 points you should take in consideration when you see the total and pattern deviation map. So you will see the first, the number of contagious difference points, the location of the difference points, and the severity of these difference points. And as we said, then you will look at the global indices. They will be on the right lower corner, to the mean deviation, to the pattern standard deviation, and to the glaucoma hemifield test. And we'll say what is the meaning of glaucoma field test in the following slide. You will see here the mean deviation, the MD. You will see here the pattern standard deviation. The mean deviation, the more negative, the more bad. The pattern standard deviation, the more positive, the more bad. And this is the probability that this deviation is found in normal population. The glaucoma hemifield test, which is the third marker, which is very important in the global indices, evaluate the asymmetry between the superior and inferior fields. They choose clusters to imitate the anatomy of the retinal nerve fiber layer. Use these clusters, compare them between the patient hemisphere, between the superior hemisphere and the lower hemisphere, and to normative age corrected database. And they will say three responses. We will talk about them: outside the normal limits, borderline, and normal. You see, for example, here the superior field compared to the inferior field, there is asymmetry difference between the superior field minus 20 decibel compared to minus 3 in the inferior field. So in the printout, you will see that the glaucoma hemifield test outside the normal, or borderline, or within the normal. They mean that the glaucoma hemifield test, or GHT, outside the normal limits, that the difference between the upper and lower defects not found 99% with the glaucoma. That this difference is found in less than 1% of normal patients. And this glaucoma hemifield test in this patient is 99% abnormal. Okay? And if you see that the glaucoma hemifield test is borderline, this means that the difference is not found in 90% of patients without glaucoma. That this difference could be present in less than 3% of normal. Okay? However, the third result is the glaucoma hemifield test within normal limits. So combining the MD, the PSD, and the glaucoma hemifield test along with the maps, you will discover that this patient has glaucoma or no. We have last index is the visual field index. Okay, this visual field index is like a global index expressing the visual field as a percentage of the normal age adjusted visual field. Give greater weight to the points close to the fixation and less sensitive to the cataract. These are the main benefits, that less sensitive to the cataract and media changes compared to the MD and PSD. However, it requires a minimum 5 tests over the 3 years. And despite that, it is less sensitive to cataract media changes, not immune to artifact. There's some artifacts can happen, like fatigue of the patient and other causes of artifacts in visual field. And also the rates of progression, as we know, decreases as the glaucoma severity increases, because it looks like it reached the maximal reduction, so it will not appear on the visual field index as a rate of progression. So it's very, very useful marker to follow the progression of glaucoma patients in every stage of glaucoma. However, in the severe advanced cases, you cannot depend only on the visual field index as a marker of progression, but in general, it's very useful marker of progression. Number 4. As we say 3 rules. Now coming to the rule number 4, the RNF layer pattern of field loss. So please always look at the pattern deviation plot, and this pattern deviation plot should be consistent with the glaucomatous damage of nerve fiber layer bonding. So if you see here the pattern deviation of the retinal nerve fiber layer, the paracentral defect with nasal stipping, with glaucoma field outside the normal, and minus 3.6 decibels mean deviation, and 7 decibels pattern standard deviation, this representing glaucoma, moderate glaucoma. Also, as we said, that sometimes the paracentral arcuate RNFL defect may be very small to be seen in 24-2. Here the same patient, if you see here, there's one scotoma, one field lost, minus 27 decibel. This is in grayscale map. But however, when you do 10-2, you will see that the paracentral acute RNF layer defect is much higher. Not only that, it's much higher. So sometimes these paracentral acute RNF layer defect, as we said previously, you can detect them using the 10-2. I'm stressing more on this point just to keep them memorized by heart. So sometimes also, as we said, the benefit of the total deviation compared to pattern deviation of the C reduction in the total deviation uh, probability map, and you see normal pattern deviation, this means that the media is hazy. Could be due to cataract, could be due to corneal haze or corneal edema. However, sometimes this cataract with generalized field loss can obscure localized effects. For example, here in this example, the total deviation map is showing total reduction generalized field loss. So if you depend only on this map, total deviation map, you'll see, okay, this is due to cataract. However, when you look to the pattern deviation, you will see severe field loss. So sometimes cataract with generalized field loss can obscure the localized effect. So you need, in order to interpret the visual field printout correctly, to always read the total and the pattern deviation maps. Here, the RNF layer pattern is the nasal loss, as you see nasal stipping with borderline glaucoma hemifield test representing early or moderate glaucoma. Here you see that there is acute loss, okay, of the retinal nerve fiber layer with glaucoma hemifield testing outside the normal. Here you see that there is hemifield loss, and this is common in advanced glaucoma. This is the total deviation map. As we said, sometimes generalized field loss can be happen due to cataract or hazy media. However, the pattern deviation showing severe hemifield loss, which is common in advanced glaucoma with outside normal limits glaucoma field test, and minus 14.3 decibel mean deviation with very high 13.13 decibel pattern standard deviation. So please look at all these parameters in order to interpret the printout very carefully. Now, coming to the rule number 5, reaffirm the diagnosis. Please, always reassess the retina and the optic nerve, seeking the consistency with visual field. You are not visual field interpreter. You are not AI model. You are clinician, physician, doctor, surgeon. So you need to read the visual field in the context of the patient examination. And please repeat the test if needed, and we will say why just in few seconds. You know that 85% of patients with abnormal fields in ocular hypertension study, they turned out normal after retesting them. So please repeat the test if needed and reframe the disease severity if appropriate. Okay? So always reaffirm the diagnosis, confirm abnormal field, even in experienced field takers. As we said that 85.9% of abnormal fields reverted to a normal on subsequent testing in ocular hypertension study. And this is one example. On 2nd April 1997, one of the patients showing inferior field defect, and when they tested after 1 week, it reverted to normal. So please repeat the test if needed. And why we should reaffirm the diagnosis of each patient? Because we have factors that affect the final result of visual field. We have factors related to the patient. Some patients, they have variable attentiveness. Some patients will be fatigable during the test. Some patients will fall asleep. Some patients are inexperienced with visual field testing. Some factors related to the perimetrics, and the rule of perimetrics was more important in the manual visual field. However, in the automated visual field, the rule becoming less. However, they have very important role in counseling the patient, explaining to the patient the test, explain where they expect to see the stimulus, how they will see it, teach them when to stop and how to stop the test. These are very important factors during the test for the perimetrist. Also, the refraction. Please always correct the refractive error. If the patient has refractive error and you didn't correct it, the patient surely will have reduced visual field, loss. So please correct the refractive error. Also consider presbyopia. And sometimes there is lens rim artifact when you, if they are too far from the lens, okay, they will not see the triggers that are touching the periphery, so it will show the lens a peripheral field loss because of the lens rim artifact. So please consider all these points before getting final results from this printout. Also the pupil size, because if you have a small pupil, the light that entering the eye will be much less. So the sensitivity to the stimulus will be much less. Okay, this is especially when the pupil size less than 2.5 millimeter or less than 3 millimeter. And we said in the previous rules that you should check that the correct test has been done during the pupil size should be always more than 3 millimeter. Okay. Now we have just a summary of how to interpret the visual field. If you see that the MD mean deviation is normal and the corrected pattern standard deviation, which is, as we said, the short-term fluctuation corrected to the pattern standard deviation normal, and the total deviation plot clean, the pattern deviation plot is clean, so this is normal diagnosis. And if you see that the MD is abnormal and the corrected standard pattern deviation is normal, with many abnormal points in the total deviation plot with a clean pattern deviation plot, this means that there is generalized loss of sensitivity, like, for example, cataract or hazy media. But if you see that there is normal MD with abnormal corrected PSD and abnormal total deviation plot with abnormal pattern deviation plot, is most probably glaucoma due to localized effects, okay, or localized effect due to glaucoma or other causes. And if you see that there is abnormal MD with abnormal corrected PSD with abnormal total deviation plot with abnormal pattern deviation plot, this means that you have both generalized and localized effects, okay. For example, this can be happening in advanced glaucoma. We have just final touch to conclude the reading, the interpretation of visual field, the Anderson criteria. This is very important criteria, perimetric criteria for the diagnosis of glaucoma. So this Anderson criteria has 3 points in order to say that this patient has a glaucoma depending on the perimetry, okay, only. The first point, that pattern deviation probability plot has a cluster of more than 3 non-edge points with probability less than 5%, at least one of them 1 point with probability less than 1%, which means that one of them 1 point, it has 99% that this point is abnormal, okay, with pattern standard deviation probability less than 5% with the glaucoma hemifield test outside of normal limits. So if you see these 3 points together, this is confirming perimetric diagnosis of a glaucoma, okay. Depending on this, some authors, clever authors, generate a web application for automatic classification of the glaucomatous visual field using Anderson criteria, and they name it as a glaucoma field defect classifier. They have the website, and their paper was published in Nature Digital Medicine Journal. And you will see here, like the website, you will upload the pattern deviation plot. This is the link of the website, okay. And then you will write the mean deviation, the global plot central decibel values, and the visual acuity option, and run analysis, and they will say you most probably this patient have glaucoma, okay. Now coming to the case studies, we'll explain some case studies in order for you to memorize by heart how to interpret a visual field, collecting all the data that we said in the previous slides. The first case, you have 57-year-old man with no complaint, vision 6/6 both eyes, with IUB 22mm mercury in both eyes, and small disc size with no cup. You will follow the 5 rules that we introduce and how to interpret a visual field print out correctly. Okay. First rule is this the right test. Okay. So you will check here the field size central 24-2. You will check the stimulus size 3y, the background 331.5 positive, the strategy set a standard, the pupil diameter 4 millimeters, there is a refractive error, and the left eye, the age of the patient, and the date of the birth. Always check please this is the right test was used. Second rule, the reliability. You look for the reliability indices on the up left corner of the printout. You will see the fixation loss. Yes, almost no fixation losses. The false positive rate and the false negative error rate. Okay. Then, so in this test, the reliability indices telling that this visual field is reliable. Then you will review the probability plots, the total deviation, the pattern deviation. You will see here that you have field loss nasally, okay, nasal step, and the total deviation and the pattern deviation map, okay, with many of them less than 1% probability. And these patterns of the retinal nerve fiber layers, nasal stepping, we call it, and the 5 rule reaffirm the diagnosis. This is moderate glaucoma, okay. And you can look for the other parameters we said here, the glaucoma hemifield test outside the normal, the mean deviation, and the pattern standard deviation. Please, if you watch this YouTube lecture, you will explain every point in this printout. Okay, please be focused. The second case is a 40-year-old man with vision 6/6, IUB 25mm mercury in both eyes, with average optic disc and superior rim thinning. The first rule is this the right test? Okay, this is 24-2 threshold test. What are the other parameters? The stimulus size, the background, the strategy, the pupil size. You will follow. You will check all these points before reading the printout. Then you will go to the reliability indices, the fixation losses, the false positive, false negative rates. You will see them that this is reliable. We said that fixation loss ideally should be less than 10%. False positive, false negative should be less than 33%. Ideally should be less than 25%. Okay. Then you will go to review the probability plots. You will see that there's some unspecific changes in the total deviation plot. However, the pattern deviation plot is clear. You will check the retinal nerve fiber pattern, retinal nerve fiber layer pattern. You will see that the glaucoma hemifield is within normal, and you reaffirm diagnosis. This is normal standard automated perimetry. Okay. So you now understand every point in the printout. The case 3. This is 58-year-old man, seen 9 years ago, with IUB between 24-28, average disc, visual field normal, and present for follow-up with IUB 22mm mercury both eyes. Now we'll combine between the two lectures I presented, between the 5 rules for assessment of the optic disc in glaucoma and 5 rules of interpretation of visual field printout. The first rule, you will observe the scleral ring in order to identify the size of the optic disc. Then you will identify the size of the rim, the is-not rule. Then you will examine the retinal nerve fiber layer. Then you will examine the region of parapapillary arch of beta zone and alpha zone. Then you will look for any retinal or optic disc. Okay, so the first rule, see the scleral ring rim. This is average disc size. Then you will see that there is inferior retinal nerve fiber layer thinning, inferior notch, so there is not rule violated. Then you will see there is diffuse retinal nerve fiber loss. There is no retinal nerve fiber loss at all in this image. Then you will see that we have beta zone parapupillary atrophy. This is the beta zone parapupillary atrophy, and there is no disc hemorrhage or even retinal hemorrhages. Okay, now this is clinically a glaucoma. However, combining these 5 R's of the optic nerve examination, visual field interpretation, you will check you did visual field for this patient. You will check this is the right test, OCS 24-2. You will go through all these parameters to check that this was the right one to use. Then you will go to the reliability indices, fixation losses, false positive, false negative. You will see that this disc is reliable. Then you will review the probability plus both the total deviation, pattern deviation. You will see nasal sieving. You will review the retinal nerve fiber layer and see nasal sieving along with glaucoma hemophysis outside the normal level. So this is moderate glaucoma, combining both the optic nerve examination and the visual field. So this is the final printout. As we said here, the reliability indices, data, relative fixation loss, false positive, false negative. This is the related to the right test, the test duration, the test strategy, the stimulus size, background, the pupil diameter, the visual acuity, the date of the test, the time of the test, the age of the patient, and then you will see the threshold numerical probability map and the grayscale map. Here you will find the total deviation map uh, along with the pattern deviation map and the grayscale maps. Here you will see the glaucoma hemifield test along with the visual field index, as we said, the mean deviation with the pattern standard deviation, and here at the bottom of the printout you will see the gaze tracker. And now, by ending this lecture, you are able to understand every point in this printout. So please read it and memorize it by heart, and you need sometimes to repeat it. And thank you all. What I give in this lecture is only the tip of the iceberg, and there is too much data about perimetry, the other types of perimetry, and the diagnosis of glaucoma. Thank you all for listening for this interesting, very important lecture.